Hello, everyone. My name is Craig Newgard. I'm an emergency physician at Oregon Health and Science University in Portland, Oregon, and I am honored and privileged to be able to present our work to you today. I also want to first recognize, support, and thank the many emergency care providers throughout our country and truly throughout the world. So all the physicians, nurses, APPs, techs, medics, and everyone else, thank you for your service and all your care in these last few crazy months. With that, I present to you a national evaluation of emergency department pediatric readiness and outcomes among U.S. trauma centers. I want to recognize my many important co-authors in this work. We are funded by a grant from NICHD, have no further disclosures. 10 academic medical centers participating, as well as 5 national organizations and 13 state departments of health. This is truly a large collaborative effort. First, some background. Unintentional injury is a leading cause of death and years of potential life lost in children. Most of these children are cared for in emergency departments. And over a decade ago, the National Pediatric Readiness Program was stood up to measure, understand, and improve the emergency care delivered from EDs, and in particular, be able to grade and score the capacity and capability of EDs to provide high quality care for seriously injured and critically ill children. It turns out that there's large variability in this readiness to care for children. And while EDs in trauma centers are assumed to provide comprehensive high quality care, as part of the most sophisticated regionalized model of care in the world, this is not entirely clear that all EDs reach this benchmark. And several important questions persist. One in particular, it remains unclear whether increased readiness in the ED actually improves quality and health outcomes in our children. This, we sought to evaluate the association between ED readiness, mortality, and complications among injured children presenting to EDs in U.S. trauma centers. This is our conceptual model. There's an injury event in which a child is involved. They are transported to the ED. The readiness of that initial ED is quantified through a national pediatric readiness survey. We track children through their hospital course, whether or not they're transferred to another ED or hospital, and then measure health outcomes and quality measures. To this, we included 44 states from 2012 through 2016, representing 841 trauma centers of a variety of levels, which participate in the National Trauma Data Bank. We matched these data to the National ED Pediatric Readiness Survey and focus on children 0 to 17 years with trauma who were admitted, transferred, or died in the hospital due to trauma. We also linked a portion of these records to state vital statistics records, which were validated in 5 states. Readiness survey was conducted from 2012 through 2013 in all 50 states and U.S. territories and included 57 questions in 6 domains. These were created by multiple national organizations and an expert panel to, again, represent multiple aspects of the capability and readiness of caring for children. The answers to these questions are then translated into an overall score called the Weighted Pediatric Readiness Score, which ranges from 0 to 100. And this was the primary measure that we evaluated for looking at ED readiness. We collected a number of patient-level variables, all which are included in standard risk-adjusted models for trauma, as well as several hospital-level variables. Our primary outcome was in-hospital mortality or serious complication. You can see the complications listed here. For secondary outcomes, we looked at in-hospital mortality, and then for a subset of children, mortality out to 1 year. For our statistical analysis, we used probabilistic linkage to match records from the initial ED to a second ED or hospital for those children who were transferred, and also to link in state death registries for a subset of states. We looked at key subgroups of children using a variety of definitions of serious injury, and we scored pediatric readiness by quartile at the ED level. We used random effects regression models, which were clustered on the initial ED, and several sensitivity analyses to test the rigor of our findings. This is a schematic of our cohort creation. We included any child for whom we had information from the initial ED, including a matched pediatric readiness survey. The only children that we otherwise excluded were children who arrived with no signs of life. Our total cohort included 312,790 children, which also included just shy of 47,000 children who were transferred to other facilities. Patient characteristics are listed here. There were just under 3% of children who had our composite outcome of either death or complications, and the subgroups are listed here. This is a histogram at the ED level measuring quartiles of pediatric readiness. And we can see that there's a fairly large spectrum of readiness across these trauma centers. I will also note that lowest quartile of readiness, over 30% of these hospitals were level 1 or level 2 trauma centers. These panels illustrate the unadjusted rate of outcomes on the weighted pediatric readiness scale. So we can see that on the low end of the scale, there's more scatter, suggesting a higher rate of complications or in-hospital mortality. However, these findings are not adjusted for important confounders and predictors. These panels present findings that are adjusted for those predictors and confounders. These come from our multivariable models and represent the odds ratios of the composite outcome or isolated to in-hospital mortality, looking at different quartiles of readiness compared against children who were seen in the lowest quartile of ED readiness. If I draw your attention to the upper left panel, we can see that for the composite outcome, this suggests a lower odds of adverse outcomes. However, the confidence interval just touches 1. When we look at mortality, this effect is more statistically conclusive. It would translate into a 42% reduction in the odds of mortality for children seen initially in high readiness EDs compared to low readiness EDs. The other panels look at the variety of subgroups by injury severity, and we can see that these findings are also quite consistent across different subgroups. This slide looks at the different domains of readiness in similar risk-adjusted models, and we can see that the personnel domain is the one that stands out as having the strongest association with improved outcomes. Personnel represents the training, background, and evaluation of providers, both physicians and nurses who staff the ED. One-year mortality analysis included just over 40,000 children. We can see in comparing in-hospital to one-year mortality that there were some children who died following hospital discharge, but prior to 1 year. And when we run the same models on this subset of children for each of the same groups, there is one subset that stands out, that is retaining that beneficial effect in reduction of mortality out to 1 year for the association with being treated in the highest quartile of ED readiness, and those were seriously brain injured children. Sensitivity analyses are represented here. We can see that for the composite outcome, as we add in trauma center level, pediatric trauma center level, and volume, the confidence intervals widen slightly to make these findings less statistically conclusive, but for mortality is very persistent despite adding different hospital level variables. That is, the effect of mortality persisted in all the sensitivity analyses. There were limitations in this study. We focused on a higher acuity population that's limited to children with trauma. Our findings also reflect that of U.S. trauma centers, which may not represent all U.S. EDs. We also focus primarily on in-hospital outcome with a subset of children. In Conclusion, injured children admitted through high readiness EDs had lower mortality and possibly lower rates of complications when compared to similar children cared for in low readiness. Translate this more simply, our results demonstrate that the initial care really matters for injured children. These findings support national efforts to raise ED pediatric readiness among U.S. trauma centers that care for children. This might be done by integration of pediatric readiness into national and state level verification programs for U.S. trauma centers. Thank you for your attention.